The wand was developed in 1997 by Milestone Scientific. What makes it unique is that it's a computer-controlled local anesthetic delivery system. Because of this, it has changed the way patients view dental injections. Currently, only half of the 52 dental schools throughout the country utilize this technology. However, many dental offices have switched to using this anesthetic delivery system. Thus, it is imperative dental hygienists are familiar with this device. Most of the advances in local anesthesia have been in the pharmacology of the drugs administered. The syringe we're used to using is basically the same as the one invented in 1853 by Charles Pravaz. The wand is really the first advancement in the syringe in 165 years, as it offers an alternative delivery system that is computer controlled that makes for a more comfortable and painless injection.
The wand consists of three main components: the drive unit, the handpiece, and the foot control. The drive unit contains a microprocessor and a step motor. It's basically a computer that controls the pressure of the fluid. There is always a constant pressure applied with the wand, and the flow rate of the anesthetic. The disposable plastic handpiece, or what we call the wand, is about $1 a piece. They are supplied in a pre-assembled sterile pack. The handpiece is connected to the cartridge via this microtubing. There is no latex in the handpiece or tubing, making it hypoallergenic. There are three different sizes of needles: the extra short, the short, and the long needle. When we're cleaning up, entire handpiece will go into the sharps container. The foot control that activates the unit and controls the two flow rates, fast and slow. Maintaining an ideal flow rate is probably the major factor in achieving a more comfortable injection. The slow rate, when we just barely depress it, delivers 1 drop every 2 seconds. Each drop contains the same amount of anesthetic. At that rate, it takes approximately 2 minutes to deliver a full cartridge. The fast rate, when we depress more heavily, delivers a steady stream, and at that rate, it takes about 1 minute to deliver a full cartridge. First, we'll attach the foot control to the front of the unit by threading it on. Then we'll attach the power cord to the back of the unit and turn on the power switch. When the unit is on, you'll see lights appear. The top lights indicate the amount of anesthesia remaining. The middle light is for power, and the bottom light is for aspiration. We'll insert the cartridge into the holder, rubber diaphragm first, until the spike punctures the diaphragm. Then attach the cartridge holder to the unit by pressing down firmly and turning. If the handpiece doesn't come with the needle already attach needle and place handpiece in receptacle. To purge, remove handpiece from receptacle and hold with needle directed down. Press and release the foot control once. After the purge, the unit automatically goes into aspiration mode and the light will be on. Then we will need to perform the aspiration pretest. With the needle bevel down, press the foot control to slow speed for 4 beeps and release. When we see the drop recede, we know aspiration is working. When removing the cartridge, press and hold the aspirate button to withdraw the plunger. Push the cartridge holder down firmly and twist to remove. With the wand, there are a few different things to know about techniques. First, the grasp is different. The wand utilizes a pen grasp, just as we would with ultrasonics. Ergonomically, this is more natural and comfortable for the operator. Just like with ultrasonics, it forces the operator to have a feather-light touch on the handpiece. The control of the wand is transferred to the small muscles of the fingers and thumb, leading to more precise needle control and dexterity, and tactile sense is enhanced. The handpiece itself only weighs a few grams, making it much less fatiguing. And the handpiece wand is held within 2 inches of the insertion point. This is compared to the rather far distance of 9 inches that you would expect with a traditional syringe. The next thing that is different is aspiration. Again, with the traditional syringe, aspiration is operator dependent because your thumb is used to create back pressure for aspiration to occur. However, the wand automatically aspirates on demand by simply releasing the foot control. And to test this, I'll press on the foot control for a few beeps, then release. You can see the solution suck back up, indicating that aspiration is working. And finally, the path of insertion is different. We are used to a linear insertion with a traditional syringe. While pushing through tissues in this manner, the needle can become deflected, altering the terminal deposition site. With the wand, we implement a birotational insertion between the thumb and index finger to overcome this needle deflection. The anesthetic pathway is also unique to the wand. The two main causes of pain associated with dental injections include 1. The initial tissue puncture, and 2. Depositing a volume of fluid too rapidly into a confined space, which results in pressure pain. The wand addresses both of these problems with the implementation of the anesthetic pathway. It is established when an anesthetic drip precedes the path of the needle. We use this for all wand injections. To establish, place the bevel of the needle against the tissue. Apply a cotton-tipped applicator on top to seal the bevel. Without penetrating, initiate the slow flow of anesthetic for 2 to 3 seconds to force some anesthetic through the surface epithelium prior to actual penetration. Traditionally, clinicians have avoided the palate as an injection site for obvious reasons. However, computer-assisted palatal injections are much easier and more comfortable than the traditional approach. The AMSA, or anterior middle superior alveolar nerve block, anesthetizes 5 teeth in one injection, the central incisors of the second premolar, and it also gets the corresponding facial and lingual gingiva. The injection site is the spot on the palate which bisects the premolars, midway between the free gingival margin and the mid-palatine suture. So we are first going to establish our anesthetic pathway, and then we'll insert to bone, and once we're there, we'll aspirate. We give 3/4 to a full cartridge of anesthetic with the extra short needle, and it should last for about 1.5 hours. One of the major benefits of this injection is there is no numbness of the lips and muscles of facial expression like you would see with an ASA or MSA. Here you can see the tissues blanching in the process, like so. The PASA, or Palatal Approach Anterior Superior Alveolar, anesthetizes 6 teeth in one injection, canine to canine, and it also gets the corresponding gingiva both facially and lingually. So first we'll establish an anesthetic pathway. The injection site is 2-part. First, you'll penetrate laterally into the incisive papilla and allow the tissue to blanch. Once blanched, we will reorient the needle to gain access into the incisive canal. Advance the needle to bone slowly and maintain contact with bony wall. Aspirate. We will give 3/4 to 1 cartridge of anesthetic with either the extra short or short needle, and it should last for about 60 to 90 minutes. Again, this injection is beneficial as the patient doesn't experience numbness of the lips and muscles of facial expression like you would see in an ASA. In addition, we are getting 6 teeth numb with only 1 injection. And here we can see the tissues blanching. The PDL, or periodontal ligament injection, anesthetizes a single tooth and the corresponding tissue, facially and lingually. The wand makes it possible to administer a PDL without the discomfort often associated with this injection. When giving a PDL on the maxilla, we inject on the facial, mesiofacial or distal-facial line angles for molars, and direct facial for premolars and anteriors. When giving a PDL on the mandible, we inject on the lingual, mesiolingual or distal-lingual line angles for molars, and direct lingual for premolars and anteriors. First, we'll advance the needle apically until resistance is met, then establish an anesthetic pathway in the sulcus or pocket. Once established, you will then puncture the junctional epithelium and then aspirate. We give a 1/2 cartridge of anesthetic for this injection with the extra short needle, and it should last for about an hour. This injection is beneficial because the onset is rapid. The patient lacks collateral numbness of the face, tongue, and lips. We can see the tissues both facially and lingually are blanching, indicating success in anesthesia.